very much. Again, you can see her in the C-suite. You can see her talking to management. Gives you some insight about the way she talked, the words she used. Now we're going to hear from Dr. Aerts, who's the head of the Novartis Foundation. For me, she brings a particular type of interest because as a physician, master's degree, PhD, she could easily have stayed with a particular disease, having looked at leprosy, malaria, and then actually managing an area of cardiovascular disease, and then going back to lung and tuberculosis. But she's going to talk now about a foundation and its role and how it impacts. So instead of the individual disease, it's the larger picture. And that's an evolution in and of itself. So Dr. Aerts, please.
Thank you very much, Clarion, for the nice introduction. And what a challenge to come after these two impressive speakers. Thank you very much. And it's a great honor to present you how at the Novartis Foundation we are looking to increase our impact in global health. In fact, the scale of the global health problem nowadays is really unprecedented with the rapid urbanization and increasing poverty rates, the unfinished agenda of infectious diseases, mother and child health issues, and the constant threat of new diseases like now with Zika. But on the other end of the crossroads, we have this rising tide of non-communicable diseases. And non-communicable diseases are not a problem of the rich anymore. They are a problem of the poor. Low-income countries carry most of the non-communicable disease burden, and 4 out of 5 deaths due to non-communicable diseases happen in low and middle-income countries. For example, hypertension, the prime risk factor for cardiovascular disease, which is the major killer, 1 in 3 deaths in the world are cardiovascular deaths. Hypertension kills 10 million people a year, and that is as many as the deaths of all infectious diseases combined. And hypertension or high blood pressure is striking at a much younger age in low and middle income countries and is killing young adults from strokes. For example, when I last was in Ghana, the wards in the hospitals are not full of HIV and TB patients anymore, thanks to the good treatments, but they are full of stroke patients who have nowhere to go because there are no rehabilitation, chronic care services available. We see, when you look at the number of population per doctors in the world, it's quite obvious how unequal that is divided. So the health systems in these countries are absolutely insufficiently prepared for addressing the needs of chronic patients. They're all geared towards acute care, none towards chronic care. So we believe that to address that, we really need to innovate the delivery of care rather than to deliver more innovations. You know, for example, hypertension has a lot of treatment possibilities available since many years. It's easy to diagnose, relatively easy to treat, except for the fact that you need to take your treatment for your life and you have no symptoms, so it's hard to motivate patients. But it's a disease for which we have a solution. So we have to be able to bring it to the people who need it. And we don't have any more time to lose. You know that from all development aid, only 2% goes to non-communicable diseases, all non-communicable diseases combined. So if you look at that, you understand how one minister of health in Africa told me last month, my NCD department is my orphan department. So there is no funding whatsoever available for NCDs. And that is what we try at the Novartis Foundation, besides, as Clarion said, our legacy work to eliminate leprosy and malaria, which we won't give up because we are almost there. For leprosy, we are covering the last miles, but that are the most difficult ones, unfortunately. The major part of our work is really geared towards finding new ways of delivering health services in low and middle income countries for the dual burden of disease. But we choose to specifically look at hypertension, not only because it can be a model for other NCDs, but also because we have a lot of expertise in cardiovascular disease. That is very ambitious, our work, but we are very focused also. And as we come from an evidence-based company, we also measure everything we do. So everything we do is based on evidence, but we want to generate new evidence so that we can translate that then into new policies. So it's a continuous cycle. And this is our classic way of working at the Novartis Foundation. So all of our success is built on our partnerships. We are never alone. We are not just, by the way, a grant-making philanthropic organization, but we are very much hands-on involved in our programs and with our partners. And for example, in Ghana and in Vietnam, we have a similar partnership now addressing in a very innovative way hypertension care in low-income urban settings. In Ghana, it's together with FHI 360 and the Ghana Health Authorities and the London School. In Vietnam, it's together with PATH and the Vietnamese or the Ho Chi Minh City Health Authorities. But in both of these programs, it's like a public-private partnership, if you want, with the local health authorities, NGOs, academics, local and internationals, to share learnings and cross-fertilize. To really have sustainability included from the beginning and also allow it to scale. Because if it is successful, a model like this, we then have to translate it into policy, and then we are obliged to turn to the government. Now, you know it works, please, can you make sure it comes in the rest of the country? This kind of working, it works. We have a lot of success stories, but it takes a hell of a lot of time. It takes between 5, 8 to 10 years. And we are too impatient. We don't want to continue working like that. We don't want to wait until we have a model that we have evidence that it works and then ask the government for scale. So we want to know better ways of doing that. But in the meantime, we learned a lot about partnerships. How do you make a partnership succeed? As you said, I think, Gary, it's an art, it's not a science. But we had some insights, and they are just intuitive, but in fact, many of them, they are corresponding to what our colleague from KPMG demonstrated this morning. But what is very important for us in our partnerships is that the key ingredients have to be that it's tailored around the reality of the patient on the ground. You can have a perfect set of interventions like happened with the scale-up study in the Nairobi slums for hypertension, was a perfect set of interventions perfectly executed who increased the blood pressure control rate in the population from 3% to 6%. It's true, it's 100% increase, but it's not what you want to achieve with a very big interventional program. You need to design it around the reality of people living in the slums. And in the slums of Nairobi, it became clear that it was because people just cannot go and seek health care. They have to find a job every day again to survive. So job seeking is much more important for them than health seeking. So you need to provide health services in places where they pass, like the bus station, or even at night, at 9 or 10 in the night, you have to have your health services, and not in a normal way like you would imagine here. On the other hand, you have to co-create your intervention model with the partners from day one. They have to be included. All of the stakeholders have to be included from day one, and the whole model or the whole intervention has to be owned by the local partners. If that's not there, we don't start. If there is no political will to do something, we don't start. And then, on the other hand, of course, it's always better to leverage expertise of different partners so that you create a synergy, that you all work towards a higher level, a higher goal. And then you also have to stick to your goals. In the beginning, you set your goal, everybody agrees to it, and then you also measure that, because the measurement will make sure that everybody is accountable and is clear about what we want to achieve together, and defining a strategy of how you're going to scale. So these key ingredients that we distilled kind of intuitively out of our programmatic work at the Novartis Foundation were then the basis to decide how we are going to work from now on. And from now on, we are going to work in a very different way. We want to have impact from the beginning. So if you look at working on the healthcare part of the whole problem only, you will only solve the tip of the iceberg. We need to also work on the socioeconomic risk factors that are underlying the whole problem of hypertension. And therefore, we don't need to innovate service delivery. We also need to do that, but we specifically need to innovate the type of partnerships. And we need to partner with non-traditional health players. We would have a much bigger impact if we do that for a much lower effort required from every individual. This is the freedom framework you all know, but it's so obvious and we don't apply it in our work. So now we are going to do that. And we are joining forces with non-traditional health players like any other type of expertise in private sector companies who are willing to join us to work on hypertension in urban low-income settings. We are going to move forward in this way. And in fact, these insights of our learnings from our programmatic work, they correspond very clearly to what is called a collective impact initiative we then discovered. In fact, the collective impact initiative is yet another way of doing business. It's not a shared value initiative, but collective impact also comes from Michael Porter and Mark Kramer, by the way, but at a later stage. And it's built. And we feel that this is what we want to translate into action now. It's going from isolated to collective impact. And there's only 5 conditions for success. So the common agenda, the common goal, that's pretty clear. Everybody has to agree on that. But then you have to make sure that all the partners from the beginning are agreeing around a shared measurement system. Because it's the ultimate test that everybody knows what you're going to do if you know what you will be measured for. And on the other hand, every partner has to do what he's best at. So it has to be a combination of mutually reinforcing activities. So it doesn't make sense that a company like Novartis would start building roads if we can work with a company working on the transportation. So everybody applies its core expertise in the partnership. And there is continuous communication, not only to learn from each other, but also to let other people benefit from the learnings of setting a thing like this up. And last but not least, obviously there is a need to glue this whole thing together. You need a strong global leadership. And this is how we are setting this up now, very pragmatically. On the ground, in 3 cities we selected based on their health needs, the highest cardiovascular mortality on Earth, and on the likelihood of success, meaning where there is political will. So for example, I just come back from Mongolia. Mongolia is the country with the highest cardiovascular mortality on Earth. And that's because it's a nomad population that is gradually moving into the capital city. More than half of the national population lives in the capital city because they are fed up with the harsh living conditions. But it means that they come into the city with their tents and they establish themselves in the capital without infrastructure, without job. The level of hypertension is incredibly high, also because of the way people eat, a lot of dried food and a lot of salt. But it's not only that. So there is a need to really address this problem. It's very high on the political agenda. So we went to see the mayor of Ulaanbaatar, and he's just such an enlightened person. He said this kind of initiative, bringing different private sector partners together and really address this in a holistic way is what we need. Here's my budget, you can go ahead. So this is how we are setting this up. In local cities, you get really strong traction to do this. The difficulty is finding the global partners who really want to bring the resources to the table, both financial resources and expertise, so the human resources. That's the more difficult part, because it's not difficult to have it as an aspirational leadership and have a big announcement from these 3 companies are going to work together. We really wanted to have an impact on the ground immediately, so it doesn't have to be aspirational. And this is where we now stand. So we are almost there. In the local partnerships, we are pretty much there. We are starting the interventions. So the partnership is bundling the resources to seed fund the interventions that are then built into a business plan that can attract investors to pay the rest of the money to scale it, or to join it with the money of, like, the city mayor of Ulaanbaatar. So it is a model that is not based on business profits for the partners, but it is based on a business plan on the ground with social entrepreneurs, public services, and other types of interventions. So it's another way of working. And with that, I wanted to let you know that for us, as a relatively small part of our big organization, Novartis is a very big company also, 130,000 employees. But what we can bring as a small foundation from a big corporate organization is that we can tap into the expertise of our company, and that is what our partners appreciate most on the ground. For example, when they need training or leadership building in HR management or finance management, we would ask our employees who do that, who are finance directors or HR directors, to go to mentor the people on the ground, our leaders in the local partners we have. And then sometimes they go to the field and stay there for some days, it's never very long, but just to understand the problems, and then they are mentors for these people remotely afterwards. And this kind of expertise is the one that is most appreciated by our partners. It's much more appreciated even than the technical support on the health side. So that is definitely what corporate philanthropy or corporate foundations can bring to the table. And with that, I wanted to present you the fourth way of doing social, playing a role in society, is that you can also do it in a collective impact initiative. So thank you very much for your attention.